Hello everybody, Adam Beyer, social worker with Behavioral Care Solutions, here with you from scenic Westland, Michigan, the atrium and a facility that I provide services at, one of my favorite non-pharmacological interventions to eliminate or reduce the prevalence of behaviors in the residents I serve. I'm with you today to discuss how to manage aggressive and or violent resident behaviors. Please turn to page 2 in your packets. First, some behavioral statistics within the field of geriatrics. Did you know that 20.4% of adults age 65 and up meet criteria for a mental disorder? Also, more than 50% of long-term care residents have some degree of cognitive impairment. 1 in 8 persons over the age of 65 has a diagnosis of Alzheimer's disease, and that behavioral disturbances occur in up to 75% of nursing home residents. Also, physically threatening or violent behaviors are found in up to 27% of residents in long-term care settings. 90% of individuals with the diagnosis of dementia are expected to develop behavioral disturbances at some point within their illness process. Page 3, please. First, and in helping to understand why behaviors occur, it's critically important for us to rule out and understand physiological and psychological causes. These can include, and for the purposes of this lecture, will include dementia, pain and discomfort, or other types of mental disorders that are poorly managed or unstable. Please turn to the next page. A diagnosis of dementia. A general loss of abilities, including impairment of memory, as well as one of the more of the following: aphasia, apraxia, agnosia, or disturbed planning, organizing, and abstract thinking abilities. This does not include decreased cognitive functioning due to a clouding of consciousness, depression, or of other functional disorders. Common forms seen in long-term cares include Alzheimer's and vascular dementia, but we need to also be mindful and aware of other causes of dementia or cognitive disorders. Some other causes include HIV, sexually transmitted diseases, Lewy bodies disease, Pick's disease, Parkinson's, Huntington's, Creutzfeldt-Jakob, the presence of a brain tumor or hydrocephalus, an existing head trauma, multiple sclerosis, prolonged episodes of substance abuse, vitamin deficiencies such as thiamine, niacin, B12, or hypercalcemia. Please turn to page 4 in your packet. The next huge factor in eliminating behaviors in our residents is determining their pain levels. Is the resident experiencing acute or chronic pain? Do they have joint or extremity pain? Do they have oral pain from poor fitting dentures? Are they experiencing arthritis in their rheumatoid or spondylitis form? Do they have post-surgical pain, discomfort, or a history of fractures or injury? We have to recognize that due to cognitive impairments, some of our residents are unable to communicate verbally when they're feeling pain. They may not be able to tell us the severity and that they require or desire pain management. Sometimes severely impaired residents may not even be able to remember that they experienced pain by the time they're around one of us so as to be able to communicate it. Please turn to the next page. I'd like to give the DSM definition of delirium. It's very important for us as caregivers to recognize and differentiate delirium from hallucination. Delirium is a disturbance of consciousness with a reduced ability to focus, sustain, or shift one's attention. There's a change in cognition or development of perceptual disturbance that is not accounted for by a pre-existing, established, or evolving dementia or a mental illness. This noted change develops over a short period of time, hours to days most typically, but you can see that in as little as a few minutes if a severe and acute infection takes hold. Please turn to the next page in your packet. I'd like next to discuss the impact of mental health on behaviors. When it's unmanaged, poorly managed, or unstable, chronic mental illness is a significant contributor to behavioral concerns in the long-term care setting. Some examples of chronic mental illness include schizophrenia and other psychotic disorders, mood disorders such as depression, dysthymia, a bipolar disorder, an anxiety disorder, generalized anxiety, panic disorder, with or without agoraphobia, impulse control disorders such as intermittent explosive disorders, and then finally personality disorders, be they paranoid, antisocial, borderline. Please turn to your next page. Let's discuss briefly environmental factors that influence a patient's behavior. First, are they experiencing over or under stimulation? Big contributor to behavioral concerns. Things to ponder are noise levels. Is it crowded? Is the lighting adequate? Is there availability for a stimulating activity for the resident? And is the stimulus within the environment as its whole too high or too low? Please turn to the next page. Social interactions. Does the resident have friends or family available to act as a support person for them? Does the resident engage with their peers or are they withdrawn? Are they comfortable with their caregivers? It's important for us to obtain insight from floor staff who work with the residents on a daily basis with regards to a resident's level of interaction with others so we can provide effective interventions for them. Along that line, are they doing okay with their roommate? Now, I understand that roommate issues happen, particularly in relationship to census, but it's important for us as caregivers to be mindful that some people just don't get along. Some ways to avoid that are to try to place people who have similar levels of cognitive functioning together. Let's turn to the next page. Some other potential contributing factors to behavioral concerns. Fear. Fear is very, very common with our elders, particularly those diagnosed with dementia and those who are newly admitted. Also, boredom. Our recreational activities should be a major part of their daily routine, and if a resident is withdrawn, maybe because of fear or a multitude of other reasons, it's certainly going to contribute to them acting out. Hunger is another big factor. People who are confused may fail to recognize that they're simply hungry. They may lack the capacity to be able to ask for a snack. Therefore, maintaining appropriate intake for our residents with poor focus or who wander or who have limited recall is an essential part of keeping them on an even keel emotionally. There's a bunch of creative ways to maintain nutrition and hydration. We can use snack and hydration carts. We can offer finger foods and pay close attention to the presentation of their foods when they're served. Let's turn to the next page. I'd like to discuss the biopsychosocial approach to providing care and how it can be related to minimizing behavioral disturbances in the nursing home. Excuse me. Basically, the biopsychosocial approach is a combination of examining the biological, psychological, and sociological aspects of a resident's life. This is also sometimes referred to as a holistic approach to treatment. and it was first proposed by a Dr. George Engel. The biopsychosocial approach is in direct contrast to the biomedical or disease model approach. Basically, it stipulates that physical and psychological health and well-being are multifactorial. This means that they're influenced by many factors. In short, the body can affect the mind, and the workings of the mind affect the body as well. Next page, please. This is of significant importance to the I-team because each department's area of specialization provides significant value in terms of creating effective behavioral plans to reduce behavior concerns. We need to utilize every aspect of our I-teams, and we can achieve success only when each team member's specialization is recognized and respected. It's important that we think out of the box when you use a biopsychosocial approach. Talk to family, loved ones, or friends. They will understand the resident better than we ever have. Also, they'll notice slight changes in the patient's presentation and have knowledge of behavioral patterns that have not been indicated in medical records. They also know what has worked at the last placement or prior to coming to the facility. On to the next page, please. Nice little diagram of how the biological, the psychological, and the social intertwine and overlap. Now, a moment on why it is very important to have a full evaluation. Disruptive and inappropriate behaviors hinder care needs. We all know this. They also result in non-compliance. In addition, they disrupt the environment and the peer's daily routine. Care can't be delivered to multiple people when one resident acts out. It's critical to have a thorough psychiatric assessment in the face of behavioral concerns to help plan accordingly to eliminate those behaviors. Next page, please. Assessing physiological components. Now we want to talk about how we evaluate what's going on with the resident. So this is multifactorial as well. We want to consider our residents' ability to communicate and then get on their level. Truly, some of the best therapy I've done in my career has been with aphasic residents who have maybe one or two word vocabularies but convey such meaning with their words and their inflection that I am very clearly able to understand. We can do this too as caregivers, and I'll talk to you about that a little bit later. Next is our resident showing signs of pain or discomfort. If so, let's move to remove that. That'll eliminate behaviors right there. Knowing the resident's medical history is huge in terms of eliminating behaviors. Many behaviors correlate with select medical diagnoses. Are they presenting with specific symptoms, such as fever, constipation, urinary retention, new onset of cough, shortness of breath? If so, clearly we would need to explore the option of an infection. Is our resident hungry? Are they thirsty? Do they need to use the lavatory, and do they have the need to communicate that to us, the ability to communicate with us? Are their hearing and visual impairments sufficiently accommodated? Have they been seen by ancillary services recently, if so? Is the resident able to understand what is being said to them? How do they communicate with their family and friends? And can we communicate with the resident along a similar vein? Is the resident responding to internal stimuli? Are they experiencing delusions or hallucinations? As I had touched on earlier, it's important for us as caregivers to not mistake confusion for delusion. And we do this by understanding our residents' social history and the course of their life events so as to be able to better determine delusion versus confusion. We can engage family members to increase our insight in this arena and then validate statements or reports that seem bizarre or strange. Please turn to your next page. Now let's discuss methods to assess and rule out environmental and psychosocial factors. Is the environment supportive of the resident's needs? Is it well lighted? Is the noise minimal? And how does that resident respond to high stimulus interactions, group activities, high traffic areas, high traffic times, or high stimuli sections of the facility? Is the ambient air temperature comfortable for the resident? Are they compatible with their roommate? This can be difficult at times. Are the activities that are available functional and dignified and commensurate with the resident's current level of capability? Does the resident have adequate and positive social interaction with family members or other residents and or staff? When you think about this for a moment, nursing home residents really truly rely on staff for socialization. So many of our elders spend most of their time in their rooms, in their beds. And the majority of the interactions they have with other human beings involve the delivery of care. This is not socialization. So it's very important to make small talk with the resident, even while delivering care, to help cultivate that sense of being adequately socialized. Also, does the resident have the opportunity to make decisions in their care plan? Are they bored or lonely? Are they sad, angry, or afraid? And if so, what happened when this occurred? What was the resident saying or doing? Were there any recent visits or changes in dynamics within their family or within the facility in general? Is that resident trying to refuse an ADL? If so, attempt to determine a pattern. On what shift did it occur? Which caregivers were present? Had there been any recent changes to the medications, routines, condition, or family dynamics? Is the resident bothered or more easily upset when around a specific peer? Was the resident looking for something? Huge trigger to behaviors in nursing home facilities. A lost personal item, looking for a pet, friend, or family member. Being based on confusion, the logical tendency would be to try to orient the resident. You didn't lose that, that's gone, you're here now. This makes sense to the common mind, but to a confused individual, it's catastrophic. Much better, in my opinion, to utilize validation therapy in this particular circumstance. Meet the resident where they're at and simply go with their thought process. I will help you look for your item. I'm sure we will find it. Then distract them with the preferred activity, snack, beverage, so they can forget about it and feel comfortable and validated that we as caregivers are there to try to help. Next, I'd like to discuss something very important to all providers in nursing home facilities: maintaining appropriate safety awareness. Please turn to the next page in your packets, and I'm going to show you the waterfall again. Now, when working with known aggressive residents, please never attempt to provide care to an aggressive resident without a peer's knowledge, and never ever attempt to handle a violent situation on your own. Get help. It's also critically important that you notify your supervisor prior to attempting to engage a known violent individual. Bring a coworker with you whenever possible. This provides safety for both yourself, the facility, and the person to whom you're trying to give care. If your resident is agitated and violence seems imminent, do not attempt to give that care. Next page, please. And if you find yourself in a violent situation, stay calm and never ever react to aggression with aggression. It only makes things worse. What I do when someone is agitated is I get more quiet and more calm. It almost always works to de-escalate somebody. If you have to restrain somebody, please remember that nursing home regulations require that we do so with our hands. We are not allowed to utilize restraining devices via state and federal regulations. Finally, remember to document the occurrence as per your facility's established protocol for behaviors and incident reporting. If it's necessary, also remember to notify the appropriate authorities. Now, a moment here. Your documentation will provide critical support in understanding for the use of psychotropic medications as are necessary. It also gives great insight to your behavior team in understanding patterns towards behavioral disturbances so we can further develop appropriate plans and minimize the prevalence of those behaviors reoccurring. Please turn to the next page. Old-fashioned picture of how people used to talk on the phone. And on to the next page, verbal communications. Verbal communication is a critically important piece to the delivery of care. So some practical suggestions to minimize behaviors and reactivity include using the patient's name and making sure you have their attention. When another caregiver is present, also reference that person by name and title. Very important that you be mindful of your rate, tone, and volume. For example, someone who's deaf, you need to speak a little more loudly to. Someone who is confused is going to hear frustration in your voice. Ergo, very important that you try to present as sounding cheerful. In the therapy world, we have something called the Rule of 5. And basically what this encapsulates is using statements and questions that total 5 words or less. Now, the magical number is 7 plus or minus 2. A lot of studies have shown that people with dementia are able to process 7, give or take 2 more words without having a negative response or experiencing confusion. Please turn to your next page. A moment on discussing things with people who have personality disorders. Character disorders are one of the most difficult psychological maladies for anybody to treat. It is not specifically a mental health issue. It is not specifically a physiological issue. And there are tons of behaviors and concurrent emotional disturbances that go along with having a personality disorder. I'd like to review a few of them with you briefly, if I may. First and most prevalent across the spectrum of the personality disorders is mistrust. Most people with a personality disorder are inherently mistrustful of others. Along that line of thinking, many character disorder individuals have shown the propensity to split others. This means dividing people, us as staff, into either all good or all bad categories. And as staff, we have to remember that this is not us. And it's not with relation to our efforts, it's what people with personalities disorder do. And unfortunately, you can be good one moment and bad the next, seemingly without trigger. Next, primitive idealization. This is the thought that magical powers are attributed to specific people, often past caregivers or physicians, whom we may remind our residents of. Next is projection, attributing our own feelings unto others to reduce the sense of our own inadequacies. Then there is passive aggression. Excuse me. Anger against self to manipulate others. This includes the use of self-harm, non-compliance, many times eating disorders, finally acting out, or other inappropriate behaviors in general. Also, there is narcissism, where one perceives theirself as all-knowing and all-powerful, or the sense of dependency, which involves a great fear of abandonment. People who have dependency issues often have unrealistic expectations, but depend on and expect others to fulfill them. There is also a no-win relationship style in which a resident can feel that they're not a good person, and since you like them, you must not be a good person either. Then there's denial. When confronted, the individual will deny that the incident or interaction ever occurred. Basically, people do this so as to not have to feel any unpleasant feelings and to avoid consequences for their behavior. Here are some brief strategies for managing these kinds of behaviors. Be direct and straightforward. And teach your client to validate ideas before taking action. We can do this by involving them in their treatment planning. Help your resident work through their feelings. If they learn to tolerate and accept their feelings as natural, then discussing them with trusted individuals will create a sense of self-awareness and emotional control. If we're in control and aware, we are not going to exhibit negative behaviors. Now a bit on projection. We discussed projection, and it results in counter-projection with us as caregivers. This is where the resident attributes their own feelings and experiences onto us. And disputing this with the resident is only going to further reinforce and increase the behaviors associated with projection. And we will do that if we are counter-projecting. So the way to avoid this is to acknowledge that their statements could be possible, then divert and use empathic comments to develop trust. We need timeouts too as caregivers. Behavioral residents can be terribly taxing, and we often, with our approach and response, contribute to behaviors occurring in the facilities. If you sense this is happening, break off your interaction or postpone the next one. This gives us some time to be more aware as caregivers. And it also ceases the cycle of never negative interactions, Okay, if you could please turn to the next page in your packets. At the top, nonverbal communications. Critically important to reducing behaviors when providing care is our approach and the way we look. I can't tell you the number of times I've seen a stressed out or visibly frustrated caregiver experience only more frustration because it showed when they tried to give care to a confused individual. In short, people with decreased cognition rely more on our nonverbal behavior than they do on our words or our actions, i.e., the way we look influences behavior more than anything else possibly could. Here's some suggestions to reduce those behaviors in response to our appearance. As a therapist, I do a self-check every time before I enter the door. I take a deep breath. I make sure I'm adequately groomed. I clear my head, put all of my burdens away, and smile. I do this 20, 30 times a day, every day. Very tedious, but necessary. Doing so affords our residents dignity and purveys a sense of respect to them. So approach them in a slow and calm manner. It doesn't hurt to keep your hands visible. And if it's possible, don't approach a patient from the back or the side. You can be mindful of your posture. If you're angry, it's going to show in your body language. Likewise, if you're stressed out, if you're sad, if you're frustrated, if you're nervous. On the right, On this page, we have a diagram of body contact and personal space. And I've listed the rule of 10-5-3. When you're working with someone who is agitated, suspicious, mistrustful, or otherwise unpleasant and unhappy, the rule stipulates that we start at 10 feet and we use verbal communication to develop trust. Make small talk for a moment. If this works well, we move closer, 5 feet. At this point, it would be logical to explain who you are and what you're there to do. Again, if there's no resistance, we move to 3 feet. Use more empathic comments and validation, a little more explanation of what's going on. And finally, if there's still no resistance, we attempt to provide our episode of care. It's very important that we respect and constantly assess a resident's level of comfort with us as we enter their personal space. Please turn to the next page. I'd like to discuss a couple of additional intervention options. First would be the use of sensory-based interventions. I'm a big proponent with the use of therapeutic touch. A simple pat on the arm or shoulder when you know someone is hurting or unhappy can convey more than 1,000 words ever will. Now, having said this, I want to add the disclaimer. Some people with mental illness have very, very rigid personal boundaries. And basically this comes down to knowing our patients and what they can tolerate. But for the most part, most people respond very well to therapeutic touch. Also, the use of music, headphones, music therapy, sing-alongs, background noise, ambient noise, even white noise are very effective in reducing agitation because it gives people with sensory stimulation issues something to focus on. Pet therapy is another wonderful way to reduce agitation, depression, any negative emotion in a resident. I think one-on-one interventions are fantastic as far as reducing behavioral concerns. It gives someone a chance to talk to somebody, an opportunity to interact, or simply be near somebody. Now, for those who may have moderate to severe dementing illness, studies have shown that use of baby dolls and stuffed animals have a very therapeutic effect in reducing restlessness and agitation by simply giving them something safe to cling to. Now, finally, a couple of behavioral interventions, and if you turn to your next page for the definitions. First, the title of the page is Behavioral Interventions. First is extinction, withholding positive reinforcement during inappropriate behaviors. Next, we have differential reinforcement, reinforcing positive behaviors or behaviors we want to increase. Rewards. An example of this would be a resident who resists showers because they're uncomfortable being bathed by a caregiver. Maybe give them the opportunity to do some of their own ADL care as a reinforcer after the bulk of the work has been done and we know that their skin condition is intact. Next would be stimulus control. This is teaching as association between a stimulus and cues. This is otherwise known as classical conditioning. Next page, please. Finally, some other interventions to consider when trying to reduce behavioral concerns. Walks with staff. This is a wonderful way to make a resident who's unhappy happy. I often say a tired resident is a happy resident. Access to outside areas. As I said, I began our lecture today. I'm in one of my very favorite spots. When the weather is mild, I bring residents to this courtyard and do their therapy. Let me just give you a quick view. Nothing as beautiful as what you good folks have in the Upper Peninsula, of course. But here in the suburbs, this is a little bit of heaven for a resident to experience. Finally, quiet areas. Reduce stimulation for those who are frustrated by the sometimes hustle and bustle that occur in activities or during shift changes. A darker room, maybe with some soft ambient music. This can go a long way to reducing behaviors when you see that someone is escalating emotionally. Conversely, during those long, gray, cold winter months, bright light therapy is shown to be a wonderful way to elevate a patient's mood. Finally, sleep interventions. Many of our elderly who lay in bed all the time have terrible disruptions of their circadian rhythms, and this can be a huge trigger to behavioral concerns if people are not receiving enough or receiving too much rest. Finally, we should consider alternate forms of pain management, such as PT, OT, massage, and other non-pharmacological approaches. Time permitting, what I would like to do next is patch into you guys and discuss how to compile a behavior plan. My hope would be to discuss a couple of particular circumstances that have been problematic for you and maybe then work as a team to come up with appropriate interventions. Regardless, it was my true pleasure to present to you today, and again I apologize for not being able to be there in person. Thank you very much for your attention.